Hello everyone, today's our point of discussion is autosomal dominant polycystic kidney disease. So as the name says, it is a autosomal dominant condition. So in this condition, the kidneys are grossly enlarged. They are grossly enlarged so that they occupy the peritoneal cavity completely. So there is no space in the peritoneal cavity. No space in peritoneal cavity. So peritoneal dialysis is not possible in this condition. So peritoneal dialysis is contraindicated in this condition. So why the cyst form in the condition? Why kidneys goes grossly enlarged? So let's come on the genetics of this condition. So in the genetics, there will be gene PKD1 and gene PKD2. They are simultaneously code for polycystin 1 and polycystin 2. These genes are present on chromosome 16 and chromosome 4. So what these polycystin 1 and 2 complex does? These are responsible for G protein signaling. G protein signaling. So the G protein signaling is responsible for our normal kidney. So in defective G protein signaling, what will happen? In defective G protein signaling, there will be increased level of CAMP. This CAMP promote the growth of cyst and development of cyst. So this is the theory that solve the mystery of developing cyst. This is because of genetics. There will be gene involved PKD1, PKD2, the code for polycystin 1, polycystin 2. These are responsible for G protein signaling. Or if any defect in G protein signaling, that will lead to cyst formation and development of cyst. So let's come to the clinical features. So clinical features are expressed in every generation. They are expressed in later phases like 30 to 40 years after. There will be variable presentation like in one generation at one age group, the person is asymptomatic or develop hypertension later, but it will develop in every generation. There will be complete penetration but variable expression. So the flank pain is the most common presentation. Flank pain is the most common presentation. It will due to cyst infection, it will due to cyst hemorrhage, it will due to nephrolithiasis. So gross hematuria occurs because of cyst connected with collecting ducts of gas. Hematuria will be seen. There will be increased risk of urosepsis, increased risk of pyelonephritis. This will lead to urosepsis. There will be increased risk of nephrolithiasis, increased uric acid storms, uric acid crystals. There will be defective renal acidification that will lead to metabolic acidosis. There will be increased chances of renal cell carcinoma. So what will differentiate this renal cell carcinoma from normal? The severity of renal cell carcinoma occurring in this condition, they are more severe than normal. So leading cause of death in autosomal dominant kidney disease. Leading cause of death is cardiovascular conditions like decreased GFR, which lead to hypertension, which lead to cardiovascular events. Or second is sepsis. So when GFR decrease down to less than 15 per ml per minute per 1.73 meter square, then we have to consider the allogeneic kidney transplant. So this will be our discussion later part of treatment. Other things in these conditions are extrarenal manifestation also present in autosomal dominant polycystic kidney disease. So autosomal polycystic kidney disease is also associated with extrarenal manifestation like liver cyst. It is the most common extrarenal manifestation. Spleen and pancreatic cyst also seen. There will be increased risk of Berry aneurysm. Increased risk of Berry aneurysm are seen because of defective arterial smooth muscle. This is also called as arterial dolichoectasia. So the increased chances of rupture of arteries in the brain which cause Berry aneurysm or subarachnoid hemorrhage. There will be cardiovascular complications like mitral valve prolapse, also called as floppy heart syndrome, floppy valve syndrome. The characteristics of mitral valve prolapse are seen late systolic number, mid systolic clicks. There are also GI associations like colonic diverticulum, abdominal wall hernia. So in the workup we have USG. So very different USG criteria are seen for a different age group, like for age group 30 to 59 years. We have more than 2 cysts per kidney is diagnostic in USG. For more than 60 years we have more than 4 cysts per kidney disease are diagnostic. The CT MRI are also sensitive, and KFT for kidney functions. Genetic testing we done for check mutations. So in the treatment part, we have symptomatic treatment for hypertension. We give ACE inhibitors. The goal of ACE inhibitors is to decrease the hypertension 140 by 90 mm aggressively. So the progression of disease is also controlled by these hypertensive drugs. And we have lipid soluble antibiotics like quinolones or trimethoprim sulfamethoxazole combination. Analgesic are like tramadol, which control the flank pain and abdominal pain. The definitive treatment is allogeneic kidney transplant. Before the allogeneic kidney transplant, we have to done pre-nephrectomy so that adequate space is created in peritoneal cavity for the receiving kidney. There is another drug group which is called as veptans. The veptans are decrease the CAMP. So CAMP is causing the defective G protein signaling. CAMP is responsible for development of cyst. So they decrease the CAMP and decrease the development and progression of the cyst. Thank you for hearing me. It is all about autosomal polycystic kidney disease.